Okay, so we can start.
Yeah. Good morning. Good evening, everyone. My name is Srikant. I'll be talking on the topic seizures and status epilepticus. So, we'll these are the objectives. We'll first clarify some of the terminologies. What's a seizure? What's a convulsion? What is an epilepsy? And where you should use these terms. What are the various differentials for a seizure? What are the classification system for seizure, especially the ILA 2017 classification? What are the various AEDs that are available for management, and what are their side effects? And then we'll look at the management of seizures and status epilepticus separately. So we'll start with a case scenario. This is a 42-year-old previously healthy male presented to the ER with a history of abnormal movements described by his wife as violent shaking episodes of the entire body lasting for 2 to 3 minutes, followed by a brief period of unresponsiveness, which are lasting for about 5 minutes. No history of similar episodes in the past, and the wife says that she has noticed 2 episodes, that is very brief, less than 1 minute, of blank staring and unresponsiveness, where the patient would rub the fingers of the left hand. On arrival, the patient's physical examination was normal. So here, the first thing you should think about, what are the differentials that you have? What are your differential diagnoses? So if you look, I mean, for a textbook differentials for seizures, there's a huge list of differentials that you can see: seizures, convulsive syncope, psychogenic non-epileptic or pseudo seizures, that is PNES, concussive convulsions, movement disorders, non-epileptic myoclonus, paroxysmal choreoathetosis, complex migraines, and the others. But with this history, we can narrow it down because it's a very typical convulsive episode kind of history. So we can narrow it down to the 4 main differentials here would be generalized tonic-clonic seizure, convulsive syncope, psychogenic non-epileptic or a pseudo seizure, and concussive convulsions. Since there is no history of trauma here, we can rule out concussive convulsions. So the first three would be our main differentials. The first thing you should know about convulsive syncope is that it usually happens in the setting of a severe bradyarrhythmia, where there is transient ischemia, I mean, transient reduced blood supply to the brain, and then the patient would have a convulsive episode. So we'll try to differentiate the first three here. So if you look at the differences, seizure, usually you will not be able to identify any particular trigger. In convulsive syncope, sometimes you might have an emotional stress or a Valsalva maneuver that the patient had performed, or orthostatic hypotension, where standing up from a sitting position would lead to a convulsive syncope, or a pseudo seizures usually might be associated with an emotional stress. If you look at the duration, the convulsive period during a seizure is usually less than 2 minutes, whereas a convulsive syncope, it never extends beyond 15 seconds. And the pseudo seizure may last for several minutes. That's one of the clues which will point you to the fact that patient is having a pseudo seizure. If you look at the tongue bites, in seizures, they're commonly found and usually in the lateral part of the tongue. In convulsive syncope, it is rare and it might be in the lateral aspect of the tongue. Whereas in pseudo seizure, because it's it's a conscious effort to bite the tongue, you'll end up biting the apical portion of the tongue. The facial appearance, especially during the tonic phase of seizure, usually patient will be cyanosed with frothing at the mouth. That is very typical of a seizure episode. Whereas in convulsive syncope, because of a transient shock-like state, they might be pale. Whereas in pseudo seizures, their facial appearance will be normal. Postictal confusion is very important. That is lasts for about 10 to 20 minutes in seizures, whereas in convulsive syncope, this is very brief. In pseudo seizures, this might be absent also. In ictus, that is during the seizure period, the myoclonus in seizures is usually synchronous and of regular amplitude, whereas in convulsive syncope, this is asynchronous and irregular in amplitude. Very typical movements that is described for pseudo seizures are side-to-side head movements, pelvic twisting, etc. So these movements would point you to a diagnosis of a pseudo seizure. And incontinence is, especially fecal incontinence and urinary incontinence, is more common in seizures than convulsive syncopes, and it's usually absent in pseudo seizures. One of the typical features of a pseudo seizure are they won't really, cause harm to themselves, especially in the face. You won't see any damage to the face when they are having a pseudo seizure, whereas when a patient is having a seizure or a syncope, they might have injuries to the face. So that is one of the typical features of seizure and pseudo seizures. So terminology-wise, seizure is actually a transient occurrence of signs and symptoms due to abnormal, excessive or synchronous neurological activity of the brain. So basically, it's a abnormal synchronous neurological activity of the brain that you term as seizures. This might have motor symptoms, might not have motor symptoms. It might just present with a behavioral abnormality. Whereas convulsions is involuntary repetitive muscular contraction. So the motor aspect of a seizure can be considered to be convulsions, whereas seizures can or cannot have, may or may not have convulsions. So this differentiation is very important, and you should not be using one term for the other. Seizure is different. Convulsions is only the motor aspect of the seizure. If you look at the ILA 2017 classification, you're broadly classifying them into 4 types. You are saying focal onset, generalized onset, unknown onset, and unclassified. And each of these is divided into motor or non-motor. And focal onset seizures, you're further dividing them into aware and impaired awareness. So previously, what you used to call simple partial seizures, now you would call focal aware seizures. If you were calling previously complex partial seizures, you will call them focal seizures with impaired awareness. So this is very important to differentiate between focal seizures, between the new classification and the old classification. The terminology simple partial is no longer used. You will use focal aware seizures instead. So, and previously what used to be called secondary generalized seizures, now it's called focal to bilateral tonic-clonic seizures. So we'll go to the main types of seizures. Focal onset seizures basically means that there is a focal pathology in the brains. Based on where the seizure is, the symptoms might vary. And retained awareness happens when there is when the patient is actually responding to the external stimuli. So if you think of aura, the terminology that you use, auras are basically seizures, focal seizures with retained awareness. Patient is awake and responding to external stimuli. He might see, experience flashing lights, hear sounds, or get some taste, might have excessive fearfulness or deja vu kind of sensation based on which location of the brain is involved. So auras are basically focal seizures with retained awareness, whereas impaired awareness is when patient is awake but does not respond to external stimulus. A typical example is automatism, when the patient will engage in repetitive stereotypical behaviors like grimacing, chewing, lip smacking. So there are oral automatisms and manual automatisms. So these differ based on which location of the brain is being involved. So what you need to understand is auras are basically focal seizures with retained awareness, and automatisms are focal seizures with impaired awareness. Now coming to generalized seizures. So generalized seizures generally, generalized tonic-clonic seizures especially begin with an abrupt loss of consciousness, and then they have 3 phases. That is the tonic phase, the clonic phase, and the postictal phase. Tonic phase is when all the muscles of the body become stiff, and this lasts for about less than 1 minute, and patient might look completely cyanosed during the phase. And then you have a 1 to 2 minute period of clonic phase where the muscles begin to jerk and twitch. During this period, patient may have a tongue bite and a frothy sputum. Then you end up with a postictal phase, which can last for about 20 minutes, where the patient is in deep sleep or might just be confused. And they might be breathing deeply, and they gradually wake up. So beyond 20 minutes, if the postictal phase lasts, you generally call it an abnormal postictal phase. And you might think about causes like non-convulsive status epilepticus in those conditions. So other causes of generalized seizures are myoclonic seizures, like where they have sudden brief contractions that affect any group of muscles, and the consciousness is usually normal in those patients. Atonic seizures are also called drop attacks, when the patients will lose their control of muscles, particularly of the legs, and suddenly collapse to the ground. Absence seizures, they usually occur in childhood, lasting for around 5 to 10 seconds, and onset is marked by behavioral arrest. So it's very commonly confused for daydreaming. So this is very important. These are the various important types of generalized seizures, and differentials will also vary based on which type of seizure you're looking at. So absence seizures, you think of daydreaming, pseudo seizures. Atonic seizures can be confused for syncope or cataplexy. Tonic seizures is mainly paroxysmal dyskinesia or hyperekplasias. This is not very important. Focal seizures might be complex migraines, TIAs, acute dystonias, or movement disorders. So differentials would also vary based on what type of seizure you're looking at. So now, if I was to ask you what type of seizure this is, so what is clear from this history is that patient has had abnormal movements, that is violent shaking of the body, which is lasting for 2 to 3 minutes, followed by a brief period of unresponsiveness lasting for about 5 minutes. So it's a typical tonic-clonic seizure with a postictal phase. And then what is more interesting is that patient is giving a history of 2 episodes of blank staring and unresponsiveness, where the patient would rub the fingers of the left hand. This is a typical automatism. So there was an initial focal onset, after which that became generalized. So you will call it a focal to bilateral tonic-clonic seizure at this point. And if you, when this patient was further imaged, they found a gliotic lesion in the right temporal lobe, which would suggest a possible etiology for this patient. Now, the next question is this an epilepsy? Now, the patient has only had a 1 episode of seizure. He has not had previous history of seizures. and he has come to you, you have examined, he's completely normal, but on CT you're seeing a lesion. Now, would you call it an epilepsy, or would you just leave it at a diagnosis of seizure? That is important. Now, the question is whether you can call it an epilepsy based on one episode of seizure. The answer is yes. So epilepsy is defined by when one of the following is there: at least two episodes of unprovoked seizures occurring more than 24 hours apart. This unprovoked seizure is important. If patient is coming in with a history of meningitis or a CVT coming with seizure, you wouldn't call it an epilepsy since you have a acute CNS insult causing it. So that is very important. At least two unprovoked seizures occurring more than 24 hours apart, or if one unprovoked seizure has happened with a further probability of seizure of is similar to the general recurrence after two unprovoked seizures. So if you have one unprovoked seizure and the risk of next seizure is more than 60% over the next 10 years, then you would still call it an epilepsy. And if the patient has a diagnosis of epilepsy syndrome. Now, this might sound very theoretical to say that one episode of unprovoked seizure followed by the 60% risk. So how do you determine that risk? So it depends on mainly three things. So if the patient has an abnormal neurological examination after the seizure, if the patient has an abnormal imaging, which is explaining the findings, they basically T2 hyperintense white matter lesions are not considered to be typical for abnormal imaging. That imaging finding should be able to explain your seizure. So abnormal neurological examination, abnormal imaging, and abnormal interictal EEG. And if the patient has a history of developmental disorder, if any one of these is present, the risk of seizure recurrence is in 5 years is more than 60%. So in that case, now you can call it a epilepsy. So in our patient, because he has a history of seizures, I mean, the first episode of seizure followed by a gliotic lesion in the brain, which based on history is because of previous history of trauma. Now you can point it to a typical, I mean, a trauma-related gliotic lesion which has caused an epilepsy. Now we would label it as an epilepsy. Why it is important to label it as epilepsy is because once you label a patient to have an epilepsy, it changes their whole life. They cannot drive. I mean, in India, Motor Vehicle Acts does not allow you to drive if you have an epilepsy, and you will have to take long-term AEDs, and you cannot do any high-risk jobs. You cannot do swim. I mean, there's restrictions with respect to swimming and all of that. So it's a life-changing diagnosis, and that's why it's important to identify an epilepsy from a seizure. So next thing is, what are the various types of epilepsy? So you have drug responsive, drug resistant, and remission. Drug responsive epilepsy is when the patient is seizure free for 12 months or a minimum of 3 times the longest pre-treatment interseizure interval, whichever is longer. So if the patient is seizure free for that much time, you would call it a drug responsive. Drug resistant is when you've used at least two appropriately tolerated and appropriately chosen AEDs to achieve seizure freedom. Even then, if you have persistent seizures, you would call it a drug resistant epilepsy. Remission is when patient is seizure free for at least 10 years and off AEDs for at least 5 years. Then you can say the patient is no longer fitting into the diagnosis of epilepsy. He's in epilepsy remission, basically. So what are the causes of seizures? So you have idiopathic seizures and you have symptomatic seizures. Idiopathic seizures is when there is no CNS insult at all. And symptomatic seizures are acute symptomatic seizure. You will call it when there's an acute CNS insult. We look at what these acute CNS insults are. Then there's remote symptomatic seizures when there's an underlying epilepsy, and a progressive symptomatic seizures when there's a progressive neurological disease associated with the seizures. So acute symptomatic seizures refers to the seizure that occurs at the time of a systemic insult or in close temporal association with a documented insult. So if the patient say has stroke, TBI, SDH, there is a clear time period between which they can be called as acute symptomatic seizures. So if they come within 1 week of stroke, TBI, or an anoxic encephalopathy or intracranial surgery, it's an acute symptomatic seizure. At the first identification of SDH, during the active phase of a CNS infection, or less than 24 hours of a severe metabolic derangement like hyponatremia or hypomagnesemia. So if they have one of these features, you would label it as acute symptomatic seizures. It's important because the risk of recurrence of these seizures is much, much lower. So you wouldn't label it as epilepsy unless this period has been crossed. So what are the causes of acute symptomatic seizures? Acute brain injury like acute strokes, meningoencephalitis, traumatic brain injuries, CVT, HIEs, or PRES, and toxic metabolic causes like drug withdrawal or intoxication, hyponatremia, hypocalcemia, hypomagnesemia, and hypoglycemia. Hypoglycemia is a very important differentiator that you need to check the glucose levels every time a patient with seizure comes. Non-ketotic hyperglycemia also can cause focal seizures, not really a GTCS. Uremia and hyperthyroidism. So these are the various causes of acute symptomatic seizures. The patient may have an underlying epilepsy, especially in adults. The major causes are mesial temporal sclerosis, post-stroke seizures, post-traumatic seizures, post-CNS infections, or because of brain tumors, or because of neurodegenerative disorders like Huntington's or Alzheimer's. So let's come to anti-epileptic drugs. The one thing you need to understand are there are excitatory neurons and there are inhibitory neurons. So excitatory neurons are basically when there is depolarization because of sodium influx, there is activation of high voltage calcium channels in the presynaptic neuron, which allows calcium to come in. Now this helps your glutamate containing vesicle to go into the synapse. This releases the glutamate into the synapse. And then the glutamate acts on AMPA and NMDA receptors. AMPA is a sodium channel and NMDA is a calcium channel, both of which help in depolarizing the postsynaptic neuron, which will then activate the T-type calcium channel. So this is the depolarization. And there are inhibitory neurons. The inhibitory neurotransmitters are primarily GABA and glycine, which release GABA from the sides. GABA then acts on GABA A receptors and causes hyperpolarization or deactivation of that neuron. This GABA is then transported into the cell via, reuptake into the cell via GABA transporters, and they are destroyed by GABA aminotransferases. So these are your drug targets basically. So we look at the main mechanism of action of the most of the drugs that we are using. So carbamazepine, lamotrigine, valproate, phenytoin, topiramate, and zonisamide will inhibit the sodium channels. Lamotrigine, topiramate, gabapentin, and pregabalin primarily acts on the high voltage calcium channels. They inhibit them. Perampanel inhibits the AMPA channels. Tigabine inhibits the GABA transporter. Vigabatrin inhibits the GABA aminotransferase. Levetiracetam acts on SV2A, which is a synaptic vesicle protein, which surrounds glutamate basically. So it prevents glutamate from going into the synapse. You have felbamate and ketamine, which acts on NMDA receptors, inhibits NMDA receptors, and you have valproate and ethosuximide, which are important, especially in absence seizures, because they act on the T-type calcium channels in the thalamus, which inhibits the possibility of an absence seizures. So these are considered drugs of choice for absence seizures. So these are the various mechanisms of actions for anti-epileptic drugs. And benzodiazepine, propofol, and barbiturates would act on GABA channels. They potentiate the GABA channels and therefore cause inhibition of the postsynaptic neuron. Okay, so let's come to the choice of AEDs. This is a very common need question, so I just put it up. The Harrison 21st edition mentions for GTCS, focal seizures, typical absence, others, valproate. Actually, lamotrigine is given as the first choice. We have not used lamotrigine a lot, but it seems that the safety and efficacy of lamotrigine and levetiracetam are the best. Lamotrigine is said to be the drug of choice for GTCS. This is primarily GTCS, valproate, and lamotrigine, and then followed by phenytoin, levetiracetam, and carbamazepine. For focal seizures, carbamazepine was traditionally considered the drug of choice, but now we also have lamotrigine and levetiracetam and phenytoin, which are considered first choice drugs. Typical absence seizures is primarily valproate and ethosuximide, and now lamotrigine is added to that also. And for other seizures also, valproate and lamotrigine stay at the top. So these are the various first choice drugs for various types of seizures. Now we'll look at various adverse effects that you will have because of use of anti-epileptic drugs. So if you're using levetiracetam, the main problem with levetiracetam who are patients on long-term levetiracetam is actually suicidal ideation. So because it inhibits dopamine release also, that causes depression and suicidal ideation, especially in young patients. So other than that, it can also cause drowsiness, which is not a major complaint and does not really interact. I mean, the drug interactions associated with levetiracetam is comparatively lesser as compared to other AEDs. Carbamazepines are known to cause tremors, myoclonus, and hyponatremia, especially due to SIADH associated with carbamazepine. This is a bigger problem with oxcarbamazepine than carbamazepines. SJS, aplastic anemia, and agranulocytosis also might occur. There is a phenomenon called autoinduction that happens with long-term use of carbamazepine. So it will induce its own metabolism, and you will see lower drug levels and reoccurrence of seizures in patients on long-term carbamazepine. Usually, the period is said to be around 2 to 3 months of carbamazepine. They will develop autoinduction. Phenytoin can cause ataxia, nystagmus, osteoporosis, purple glove syndrome, SLE, and SJS. It is also known to cause severe hypotension because it's a class 1B antiarrhythmic also. So that is another problem with phenytoin. It has several side effects and it's also an enzyme inducer causing low levels of other drugs, which might be an issue. Valproate is hepatotoxic. That's a major issue with valproate. It can cause hyperammonemia. Sometimes it can cause Parkinsonism and weight gain also. And lamotrigine is comparatively a safe drug, but it can cause Stevens-Johnson syndrome. And lacosamide, the main issue is a mild QT prolongation also. So these are major drugs that we use and the side effects associated with these drugs. So we can do some genetic testing to predict adverse drug reactions. Like HLA-B1502 is used to predict serious skin reactions used with carbamazepine, phenytoin, and lamotrigine. And 3101 positive patients are usually at high risk for carbamazepine sensitivity, but this is only for European or Japanese ancestry. So coming to status epilepticus, which is a major emergency. So basically, it's a condition which is resulting from either failure of mechanisms responsible for seizure termination or initiation of mechanisms that lead to abnormally prolonged seizures. So there's one thing that you need to understand here. If you go back and look at this diagram, what happens when you have a continuous seizure is that you start having internalization of GABA receptors. So the GABA receptors, which are the inhibitory receptors, will start getting internalized. So you no longer have GABA receptors. So the longer the seizure lasts, it becomes more and more refractory to your medications. And you'll have increase in the AMPA and NMDA receptors, because of which the excitation keeps increasing. So the longer you let the seizure stay, the more refractory it is going to become to treatment. So it is very important to treat it as soon as possible. So that is why status epilepticus, along with its other complications, is considered a medical emergency. So the operational definition for status epilepticus is if a seizure is lasting for more than 5 minutes of continuous. I mean, if it's a continuous for more than 5 minutes, you would consider it a status epilepticus. Or if there is at least two discrete seizures between which there is incomplete recovery of consciousness. The assumption is that if the patient is not recovered consciousness, he is probably still in a state of non-convulsive status during that period. So ILE actually uses two time points to define this, that is T1 and T2. T1 is after which it is unlikely to stop simultaneously and you will require a drug to stop that seizure. And T2 is when there is significant risk of long-term complication because of the seizure itself. It can cause neurodegeneration and cerebral ischemia and further complications because of that. So T1 for GTCS is 5 minutes, after which it will not stop simultaneously and you will have to treat it. T2 is 30 minutes. After 30 minutes of GTCS, it can cause long-term complications for the patients. Focal seizures with impaired awareness, T1 and T2 is double of that of GTCS, basically 10 minutes and 60 minutes. And for absence seizures, T1 is of 10 to 15 minutes and T2 is actually unknown for these patients. So we look at non-convulsive status epilepticus now. The status epilepticus without any prominent motor symptoms. They might have some motor symptoms, but it's not a proper convulsion basically. So this occurs in about 50% of patients with coma or convulsive status epilepticus. So you have to suspect non-convulsive status epilepticus in any patient with altered mental status, especially if they have a history of seizure disorder and they're coming to you with altered mental status. You should always consider this to be a possibility. It is very common problem. As you can see, 8 to 37% of general ICU population have it, 12 to 33% of post-cardiac arrest, and 8 to 35% of TBI patients also have non-convulsive status. So when should you suspect it? Any alteration of the, I mean, any unexplained alteration of behavior or mental status should make you think of a non-convulsive status. So what are the suggestive features? If they have ocular movement abnormalities like eye deviation and nystagmus during this altered mental status, you should think about it. If they have automatisms like lip smacking, twitches of the face and extremities, you should think about non-convulsive status. Episodic tachycardia or ictal tachycardia, that is when the patient is having a seizure and the patient is completely, I mean, comatose. If you are seeing a sudden onset tachycardia, which is unexplained, you can think of a non-convulsive status epilepticus. This is because of autonomic disturbance associated with the seizure. And you may have EEG and clinical improvement after giving an IV benzodiazepine. So if you think of a patient having a seizure, just give a dose of benzodiazepine and look at the response. If the patient is actually waking up or the symptoms of the altered mental status are improving, then you should think of a non-convulsive status. That actually proves your diagnosis more or less. There are some diagnostic criteria, but it's not very important right now. So this is diagnosis by EEG criteria for diagnosis. So basically, you have more than 10 minutes of seizure activity and seizure activity occurring for more than 20% of time over a space of 1 hour. This is not very important because EEG is not something that we commonly perform as such. The management, you maintain the airway, breathing, and circulation. It's very important while performing an RSI for patients with seizures to use appropriate medications, especially paralytics. You should prefer short-acting paralytics. If you have something like cisatracurym or succinylcholine, it's good enough because usually succinylcholine is only contraindicated when you have hyperkalemia or features of rhabdomyolysis. Unless the status has been going on for that long, it does not happen usually. So the problem with giving long-term paralytics is that you won't know whether the patient is continuously seizing, and you generally require a continuous EEG monitoring to actually diagnose seizures then. So use short-acting drugs when you're trying to intubate patients, and breathing and circulation management would remain the same. Usually patients won't be hypotensive when they're having seizures. So it's important to know that. And never forget glucose. Always when a patient comes with seizure, always check their glucose levels, because hypoglycemia is an easily treatable cause for seizures. So first line is again benzodiazepine. If IV access is available, lorazepam is the first choice. It's very clear that if you among the benzodiazepines, which is lorazepam, diazepam, or midazolam, you should prefer lorazepam because it has a longer onset of action, and patient when they look at it, they look at seizure free at 60 minutes. So usually lorazepam, because of its long duration of action, will the patient will be seizure free at 60 minutes. And this was studied in a trial called Veterans Affairs trial. There are also other trials which looked at lorazepam and diazepam. Usually lorazepam ends up having the highest success rate. But if you have no IV access, the best drug would then be to use either an intramuscular or intranasal or buccal midazolam, which is 10 mg. For children, they do use rectal diazepam, but not really for adults. The dose is lorazepam 0.1 mg per kg, 4 mg max at the rate of 2 mg per minute. Diazepam, the dose is 0.15 mg per kg up to a maximum of 10 mg per dose. And midazolam is 0.2 mg per kg up to 10 mg per dose. This is important. The problem with midazolam, it's very short acting. If you're giving a single dose, you will have to repeat it after some time because if the patient is not responding to seizures. Lorazepam, usually there's no question of repeating it because duration of action is long enough. So one thing that we are commonly afraid of while giving benzodiazepine is that, if I give this dose, patient might not breathe. Patient may have respiratory complication. That is not true. So the priority is actually to terminate the seizures, because it has been found that seizure is the one that causes more cardiovascular and respiratory compromise rather than the drug. So this was looked at in a pre-hospital trial where they compared lorazepam, diazepam, and placebo in out-of-hospital seizure patients, and they gave patients benzodiazepine. Some patients got placebo pre-hospitally. What they found is patients who received benzodiazepines have respiratory and cardiovascular complications, about half of it. So it's very important to terminate the seizure first. Forget about the complications of benzodiazepine. Appropriately dose your benzodiazepines. What I mentioned before, 10 mg midazolam is what you should be giving. Even if you're giving IV, you should give 10 mg midazolam. If you're using IV drug, it's better to use 4 mg of lorazepam instead of giving midazolam. You should appropriately dose your AEDs, because the termination of seizure should be your priority. And in terms of the second line, remember, though I'm saying second line, first line and second line has to be given together. It's not like first line you give and then you wait for seizure to go and then you give second line. It should be given simultaneously. So second line is either levetiracetam, phospheniton, or valproate. So levetiracetam is dosed at 60 mg per kg over 15 minutes. So we frequently underdose levetiracetam. We usually give around 20 mg per kg, which is not sufficient. Now the American guidelines have also changed their recommendation to 60 mg per kg. So 4.5 grams for a normal adult would be an appropriate dose, but then based on the weight, you can change it to 60 mg per kg. Phospheniton is 20 mg per kg phenytoin equivalents at the rate of 10 to 150 phenytoin equivalent per minute. Basically, phenytoin is dosed at 20 mg per kg, and phospheniton is around 1.3 times that dose. And valproate is dosed at 40 mg per kg over 4 to 5 minutes. So this is very important, and there is no preference. You can use any of the three, especially as a loading in status epilepticus. There is no difference between all three. This was studied in the ESET trial. I mean, basically, all the trials that looked at this condition basically showed that they are all equally efficacious. Only in some conditions you can prefer one over the other. For example, if the patient has liver failure, you would prefer levetiracetam. You would avoid things like valproate or phenytoin because they might worsen the liver failure. And patient with toxicological causes, you should avoid phenytoin as antiepileptic drugs. If you're suspecting a patient has taken some medication because of which he's having seizure, avoid giving phenytoin, especially it can cause severe cardiovascular complications in those patients. So treatment in first and second line should be given within 10 to 20 minutes of status epilepticus onset. Now, after the patient has not responded to first and second line, now the evidence for the use of drugs is very poor. After this, what to do is not really clear because it's not really been studied. So the agents that are available are propofol, midazolam, phenobarbital, ketamine, and lacosamide. I mean, I'll send the presentation so you can look at the doses later. But whichever you use, basically, you prefer a drug which has not, I mean, which you have not used before. In the sense, you should not use the same line drug that you have used previously. So if you're using something that's a GABA potentiator, it's better to use something that blocks NMDA now. I mean, ketamine might have a better success. So you can think of receptors at that point to terminate the seizures. So this is a basic algorithm. So ABCD first, you will give airway, lateral decubitus, nasal trumpets, oxygen and all initially. And then the first line agent would be given, which was benzodiazepine within first 5 minutes. So this is not first 5 minutes of seizure onset. This is first 5 minutes of the patient coming to the ED when he's status epilepticus. If it is first 5 minutes of seizure onset, you can actually wait for the first 5 minutes. If it's the first seizure, before giving a medication because usually it terminates by itself in the first 5 minutes. So within first 5 minutes of ED arrival, you will give your benzodiazepine, and then the second line agent will be given along with it, either levetiracetam, phosphonate, and valproate. And then if you can consider RSI at this point, if the patient is requiring anesthetic medications like propofol, midazolam, ketamine, or lacosamide, whichever you're using. Super refractory. So I think I've not mentioned refractory. So if the patient has not responded to first or second line medications, then you would call it a refractory status epilepticus. And super refractory is when the patient has received a anesthetizing dose of antiepileptic for at least 24 hours. For example, if the patient is on midazolam infusion, propofol infusion, and after receiving it for 24 hours, the patient is still having refractory seizures, you would call it a super refractory. Or after giving it for 24 hours and you stop it, patient again develops seizures, it's still super refractory seizures. So it is unresponsive to midazolam, propofol, or thiopentone infusions. So alternative options when you have a super refractory are use other AEDs like topiramate, clobazam, perampanel, lidocaine, verapamil, magnesium sulfate, inhalational anesthetics. This is not very effective as such as of now. Non-pharmacological management like repetitive nerve stimulation, vagal nerve stimulation, and transcranial magnetic stimulation, electroconvulsive therapy. Ketogenic diet has found to be useful in some patients. And in patients with new onset refractory status epilepticus, the assumption is that they have some autoimmune encephalitis which is causing it, in which case pulse, methylprednisolone, IVIG, Plex, or IV rituximab might be helpful. So that's about it for today. Thank you.
Thank you, sir. I think that was a very wonderful presentation, and the slides were really amazing. Some of the best slides I've seen actually on this particular topic.
Thank you.
Sir,
does anyone have any doubts?
yes, I think this is a good time to ask some doubts. If nobody's having any doubts, I'll ask some doubts because I have a few.
Yeah, I'll try to answer them.
Sir, so it's very common that these patients will get intubated, but what is the exact time frame when you need to intubate?
No,
15
man, that's
minutes,
a
30
very
minutes?
there is no time frame, man. During if the patient has arrived and you're given your first dose benzodiazepine, or if the patient has been seizing for a long time, once you give your first line, and you assess the patient is not improving, it's within 5 minutes. I think you should go ahead and intubate, especially looking at the vitals. I mean, the primary survey is very important there. So as soon as the patient comes, the patient is hypoxic, then you have to intubate. I mean, you give your propofol, as I said, as a induction agent, and go ahead and intubate those patients. So it's very contextual as to when the patient comes during the seizure episode and how much of a complication he has developed. Aspiration is also a huge risk in those patients. So if patient has ended up vomiting or drowning in his own secretions, you should go ahead and immediately intubate. So you cannot say that after for 10 minutes only I'll intubate. So that is very important.
That's it. So because we have this T1, T2 cutoff, like you said, and I think the guidelines say that it's better to intubate before T2 at least. I think
Yes.
often practically what I've seen is that a lot of people will give some medication and wait and watch. And it might be some 40 minutes, 50 minutes before they actually start thinking about intubating.
So I think when they say wait and watch, they might be waiting and watching for the postictal period to end. If the patient is persistently seizing, I don't think they should be waiting and watching. So post-ictal phase, you can wait for 10 to 20 minutes. I think beyond that, if the patient's airway is not maintained, you should go ahead and intubate. There is more than enough evidence to say that beyond 20 minutes, there's high risk that there's a non-convulsive status happening. So I mean, it's better to go ahead and intubate and then nicely sedate them so that the possibility of non-convulsive status is abolished.
Then coming to post-intubation sedation, midazolam infusion versus propofol, this decision mainly based on the hemodynamics, whether BP is on the higher or lower side.
Actually, man, both midazolam and propofol are known to cause hypotension. So, propofol is implicated in causing severe hypotension, if especially given in bolus states. But in infusion, both of them are more or less equivalent. So, if you're in, I mean, post intubation, if you want to give one of those, it's more or less. I don't think there's any evidence to say, prefer one over the other. Especially third line medications, I don't think we have any evidence at all to guide what our third treatment would be.
And next thing is diagnosing non-convulsive status. I think in the ED, when you have so many patients, I think this is a little difficult. If the patient is not having a non-seizure disorder, if it's a non-seizure disorder coming with status, then it's like you have a high index of suspicion. But what about patients coming with other conditions like some other acute brain pathology? They are intubated. Should we start pushing for an EEG in those kind of patients if it's possible?
If you have not found any cause, if you don't have anything explaining the altered mental status, neither metabolic nor I mean in terms of neuroimaging, then I think you will have to push for an EEG, because that is what is recommended. Any patient who has not woken up altered because of altered mental status because of any cause, EEG is definitely one of the investigations that you would perform before I mean saying that it's cryptogenic.
Definitely. I think there'll be a lot of hospital to hospital variation, but especially when it comes to feasibility of EEG and how it gets done. And it's interesting that lamotrigine is the drug of choice these days. Here, at least, I think most of the patients will be started on levetiracetam. Mostly, I think mainly because it's pretty safe. With lamotrigine, you have this risk of SGS and all, which everybody's really afraid about.
No. Risk of SGS with lamotrigine is actually very, very rare, but that is the only complication that is known to happen with lamotrigine. That's why we say, but it's very rare. Actually, even in pregnancy, they say that levetiracetam and lamotrigine are the only two drugs which have been found to be safe. So I think both of the drugs are safe, but then levetiracetam, because of availability, I think we are using more. I also got shocked after seeing this Harrison recommendation for everything is lamotrigine.
We are not using it that much, actually.
Yeah.
It's like here. So, does anybody have any other doubt that I'd like to ask now? A couple of other things, mainly about the ED point of view. So, when the patient is coming with the transient loss of consciousness, the DDs are often going to be this only, syncope versus seizure. And another, then the PNES also comes into play. Those are some very, very common things that we see. And the diagnosis is often difficult. It's not as easy as it seems. I remember one case where one patient, he was actually being evaluated in another hospital in another state. They were saying Puri seizure under evaluation, MRI was normal, EEG was normal, etc., etc. That was happening for a few months apparently. Patient came here. I took an ECG. He was having a complete heart block, which yeah, so, which apparently nobody had thought of doing before that. So it makes sense to get an ECG done if you're not sure. So it definitely won't cause any harm to getting an ECG done in these kinds of patients. Second thing is with PNES, PNES and seizure disorder can coexist. So I think it's like 1/3 of PNES will actually have a coexisting seizure disorder. So that case things become really difficult to actually differentiate. And we do see patients with PNES being on anti-epileptics also. So I think they get discriminated against quite a bit by a lot of people. So I think we have to keep this thing in mind. So they're not trying to actually fake things. They can actually help what is happening to them.
Yeah.
So I think we
So
have
actually, one
to
of the
keep
major
that in mind.
complications of having epilepsy is that they develop psychiatric disturbances. That is, even if the patient is epileptic, the most common long-term complication among epileptics is having a psychiatric, either depression or anxiety disorders. Is a very common among epileptics, and them developing PNES is a very common phenomenon. So in those cases, I think if you're not able to differentiate, it is better to get an, expert opinion in those cases. I don't think we need to know exactly what is which. Even I don't think experts would be very easily differentiating between the two. But if there is any doubt that it's status epilepticus, I think it's better to treat it off if your expert opinion is taking time.
So another thing is use of lactate in diagnosing these tricky conditions. Usually in seizures, we get a huge, very large but very transient elevation in lactate. So can we use that as something to differentiate between seizure and pseudo seizure?
Yeah, definitely. So there are biochemical markers which help differentiation. So like I mentioned, there's CPK, there is prolactin, there is lactate. Easily available would be lactate and CPK to differentiate, because they would generally suggest a hypermetabolic state. But then you shouldn't only rely on lactates or CPK. You should also use, the history is a major differentiator between all of these. So the biochemical would only come after that. So your history and physical examination would be most important, and lactates might give you an idea as to which direction it's going.
So, I think those were the points that I wanted to add or ask. So if anybody else has any doubts, they can ask right now. Otherwise, we'll be bringing this to a close.
Okay, man. Thanks everyone.
So I'll just stop the recording now.
Yeah.